Tervetuloa Komppi-TV:n ensimmäiseen haastatteluun. Olemme teidän Strandholmin kanssa tapaamassa professori Doeringia Wienistä keskustelemassa transferenssifokusoidusta psykoterapiasta.
Okay, so welcome to Finland.
Thank you very much.
How has it been?
Well, it's a wonderful place. It's very cold in Finland.
Mm-hmm.
It's dark and it's snowing and there's a traffic chaos outside, but I love it.
Yes. Okay, so we're going to talk about psychotherapy and TFP. Could you tell us about that?
TFP is a transference-focused psychotherapy that was developed by Otto Kernberg, and it is specifically tailored for patients with severe personality disorders, borderline personality disorder, but also narcissistic or paranoid, hysteric personality disorder. And it is a kind of a psychoanalytic psychotherapy that is derived from psychoanalysis. It employs techniques of psychoanalysis, but there are some specific modifications, which is we don't use the couch. It's a face-to-face setting like we are sitting here. Usually it's twice a week, not 3 or 4 times like psychoanalysis. And the most important modification is that we use a treatment contract for limit setting. If the acting out is too intense in borderline patients, we then give up technical neutrality, which means that we tell the patient, for example, to stop or to keep to what we have negotiated in the contract, not to threaten the treatment or to threaten their own lives or the lives of others. So this is typical that we set boundaries to the treatment to create a situation where we then have room and freedom to work in the transference. And that's the core aspect of transference-focused psychotherapy, that we are dealing with the relationship between psychotherapist and patient in the here and now of the treatment situation.
Okay, so if you have had to explain this to a non-clinician, how would you explain the transference?
I would tell the patient or the person that we all transfer all the time. Transference simply means that we are not free of earlier experiences we have made in relationships, particularly when we were children. So we tend to experience people we get to know, people we meet, as if they were behaving as if they were like our mother or father or important other person. And after experiencing them like this, we treat them as if they were like this. And this more or less induces a behavior in the other person that corresponds to what the earlier objects, the earlier people in the patient's life did. So for example, if I was treated in a negligible way, parents didn't take care of me, left me alone, and then I would meet my psychotherapist. I would expect that he or she would treat me the same way, that he or she would be like father or mother, and I would maybe already feel abandoned. And then maybe I would tell the psychotherapist, so you don't like me, you don't take care of me, you have so many patients, you don't give a shit on what I'm feeling and what I want to talk about. So this would be a transference manifestation, because the therapist maybe is not at all like this, but the patient experiences him and treats him as if he was like the parents, for example.
Okay, and what does the therapist do in this situation?
This is very specific for psychoanalysis and also transference psychotherapy, that we focus on these manifestations of the transference. In other treatments, we try to avoid them. We confront the patient with reality, tell the patient in easy words, I'm not like this. In transference-focused psychotherapy, we would internally feel and say, that's interesting. So here we see the problem patient has in his or her relationships live on the table. And then we would open up a space, an internal space. We would identify with the role the patient is assigning to us, and then we would start to discuss this, to analyze this with the patient. And for example, tell the patient, you give me the impression that you now feel that I'm not interested in you, that you now feel abandoned or neglected by me, that you feel that your therapist is not taking care of you at all. And then we would start to motivate the patient to talk about his or her feelings and fantasies that are related to us. And we are convinced that this is a very powerful way to change these internalized relationship experiences and to correct them by giving the patient the chance to make a different experience with us. But this is only possible if we deal with it. If we, right from the beginning, tell the patient, I'm a nice person, I would never leave you alone, then this topic is dead. And it can't be negotiated, it can't be analyzed, and things remain unchanged.
Yes. Okay. And this is a treatment for borderline and different kinds of personality disorders. Are the treatment contents different for like narcissism and borderline? And
basically, it's the same way we use it. There are different manifestations of the transference. For example, in narcissistic patients, there are specific patterns that occur. Very frequently we see a negative therapeutic reaction, for example, that if the patient made a progress, understood something started to change internally, then the patient deteriorates. There is more severe symptomatic, the patient tells us that he or she feels worse, and we assume that this is a reaction to the fact that the patient feels that we might be helpful, that we might be a good object. And this provokes the fear to become dependent on us and provokes the fear to be inferior, because the one who can help me is the powerful one, is a person I need, and this is hard to bear for someone who is a narcissistic personality. So this is typical, and we have to know this, that these problems can occur, these constellations, and have to deal with them, but basically it's the same way of treatment using the same techniques.
How is this method maybe related to mentalization-based treatments?
Well, both are psychodynamic treatments, psychodynamic psychotherapies, based on psychoanalysis. But mentalization-based therapy is much more supportive, as we would say. It is a different attitude the therapist takes. So the therapist would say is standing next to the patient or behind the patient, is supporting the patient in understanding what's going on and changing. And they would not primarily address the transference, but try to avoid the transference. They would not give interpretations, what we do, to try to put up a hypothesis about the psychodynamics, about what's going on underneath the behavior, but the MBT therapist would try to develop new ways of thinking about the things that are going on in the external world, the patient's external world. So we would say it is a method to stabilize the patient and to overcome symptoms. And we believe that transference work with psychotherapy maybe is more complex, maybe takes longer, but is more powerful in changing these internalized relationship patterns and, in the end, the functioning of a personality. So we have data that show that this is working in transference work with psychotherapy.
Yeah. And what kind of research has been done?
There are a number of research projects and a number have been published. We do have 3 efficacy studies, 2 of which very clearly showed that transference-focused psychotherapy is superior to treatment as usual or to other treatments. So it is an empirically validated therapy. There is a treatment manual, and the Cochrane review on psychotherapies for borderline personality disorder counts TFP among the big 4, as they say, big 4 psychotherapies for the treatment of borderline personality disorder. The other ones are dialectic behavior therapy, mentalization-based therapy, schema-focused therapy, and transference-focused therapy. These are the 4 treatments that are empirically validated for borderline personality disorder. And of course, we do have process research on the mechanisms of change, and there are several studies being done on neurobiological changes. So it could be demonstrated in a pilot study in New York that specific brain areas change their activity patterns after 18 months of TFP compared to the baseline before TFP.
Okay. What kind of training is there for the TFP therapy?
We offer training curricula all over the world that consist of about 70 hours of theoretical training, which means like 4 weekends, and then 2 years of treatment of a borderline patient under continuous supervision. And we assume that this is the most important part of the training, that you treat the patient yourself, that you have intense supervision, and people are learning by doing this method. Of course, you need some basic psychotherapy training, some training therapy that you've had yourself in one or the other method. It's not restricted to psychodynamic or psychoanalytic psychotherapists, but you have to be some basic training, and then this is something you are doing on top of it to specialize in this treatment for borderline patients.
Okay, so could it be a cognitive therapist?
Of course, there are a number of cognitive therapists who then learn transference-focused psychotherapy. Some aspects like the contract are more CBT, cognitive behavior therapy techniques than psychoanalytic ones.
Right. And how did you yourself get interested in TFP?
But for me, it was clearly the work of Otto Kernberg, the founder of TFP, that I read when I was a medical student, and that really fascinated me and helped me to understand the first borderline patients that I met in psychiatric departments and also in private life, where you can encounter them quite frequently. And for me, this was a fascinating door that was opened, and I tried to meet him and to get to know his thinking and working, and learned transference-focused psychotherapy from him and his colleagues in New York, and then we started to do the same in Germany and Austria.
Okay. Yes. Interesting. What else would you like to tell us about TFP? Or?
Well, I hope that's the reason why I came to Helsinki, to this wonderful city, and to meet these wonderful people. I hope that we managed to establish a training curriculum on transference-focused psychotherapy also in Finland. And I would be happy if we succeed to gather some people who are interested in this treatment, and who then will help us to establish a group, TFP group in Finland, and to offer continuously training curricula in transference-focused psychotherapy.
Maybe I could ask, are you familiar with ISTP, which is a short-term intensive psychodynamic brief therapy?
Not in detail, to be honest.
Because there's some parts that are similar or sound similar, but of course in many.
Usually the difference to the psychodynamic short-term treatments is that they do have supportive aspects and make use of supportive techniques, which means, for example, explaining something to the patient that's going on. And in TFP, we would very consequently abstain from doing this, and would just interpret, just giving the patient a hypothesis about what's going on here and now in the relationship without explaining it to the patient. So I would say we help the patient to understand and to do the work him or herself.
Yeah.
And if you have a restricted time frame, like 20 or 40 sessions only, you're unable to complete the process like this. So you need other techniques. It's not better or worse. But if you have a limited time, then you have to focus on certain aspects, and have to, of course, be more teaching or more discussing skills and very pragmatic issues for the patient to change specific aspects of his problematic symptoms or personality is difficult to change. within a brief period, I would say.
And if there would be a very successful therapy with the TFP method, what would be different in the borderline patient before and after?
Well, from our treatment studies, we know that part of the patient, like 1/3 of the patient we treated in our study, improved really a great deal. Another third improved slightly, but not the whole way we would like them to take, and the last third did not improve. So this is just from one study, we cannot generalize. But these 30% or 35% of patients who really improved very much are extremely impressive. I remember one young woman that began as like a 19-year-old in Vienna, and she had no education, she had no job, she had no family or partnership, and was really like living under the bridge, came with nothing, severely self-harming behavior, and was a very, very ill woman. And she was then treated for 1 year within the study and continued another 5 years. So we had 6 years altogether. This is a very long transference of psychotherapy. But in the end, she was a student. She moved to another town, studied something at university. She had a partner for a few years, was living with a partner, and she was really leading a normal life. And her personality functioning, that was also assessed in the study, was normal. So she really made the way from a borderline disorder to a normal personality, which is not guaranteed for everybody. But we could show that in like 30-35% that this occurs, that patients really are not borderline, are not personality disordered, and function quite well and live normal lives.
Are there other personal influences, theoretical influences for you?
You mean for my personal way to do
Yeah,
psychotherapy or for TFP?
probably both.
Yes. Well, I think what was most important for me was an aspect that's also included in TFP and also important for Otto Kernberg. Maybe in my department in Vienna there is a long tradition, and we emphasize it even more, which is a Kleinian way, which goes back to Melanie Klein, and also Wilfried Bion, where we have a very specific way of understanding the unconscious and non-verbal communication between patient and therapist, and that we assume that there are basically the most important things going on under the surface and before the spoken words occur. And this theory of containment of Bion, which means that we first have to accept the role that the patient assigns to us in the transference, and then open up our internal stage and engage in fantasies about what could be going on if we were doing this and this and that. And then we make use of what we feel and understand, and then have the patient to understand his or her part in his or her projection. So this is a very specific Kleinian way of working that of course has influenced all psychodynamic treatments, but for me it's really much at the center of my thinking and working with every patient. So maybe this is the most important influence.